Hello, my name is Liz Arjun. I'm the project manager for Health Management Associates, and I'm joined by my colleagues Nora Leibovitz and Shane Mofford from Optimus. And we are recording this presentation for our Universal Healthcare Work Group in advance of the August 2020 meeting. Thank you all for taking the time to watch this presentation and come prepared to dialogue on August 25th. So just a little background on what we're going to be doing at the August 25th meeting. We'll be spending, the main goal is to further refine the draft straw models that we've been discussing, and then start talking about the qualitative elements and criteria that we have prepared in the past that will help feed into our final report. So the plan specifically for the meeting is to get an update on what's happening with the modeling from our actuaries and the three models that we've been discussing, discuss some important key elements that they need additional information on, including cost sharing and provider reimbursement, dive back into the qualitative assessment criteria that we developed a few months ago, confirm our action items, and then hear from the public. So just getting to today's presentation, we'll be focused again on providing some background for you on cost sharing and provider reimbursement, and providing more information on the qualitative assessment criteria that we developed back in February. So just to kind of ground us in where we've been and where we're going, we've spent some time in past meetings defining and understanding the problem and then going into root causes. We've used that information to develop qualitative assessment criteria, basically what matters to us in trying to push forward a specific model for universal health coverage. We've also spent time developing some common language for different models that are being deployed globally and also here in the States, so that people are speaking one language when we're talking about these three models. We then used surveys and based on what folks identified as qualitative criteria to then narrow down to three straw options that we felt best addressed what the priorities of the work group were. And in the last meeting, we've spent time then refining the various components that make up those straw options so that our actuaries have enough information to begin doing the financial analysis. So again, so at the plan now is to then at our August meeting, use our breakout session capacity in the Zoom to begin diving into, but continue our analysis and discussion about what type of cost sharing our work group thinks should be or not be in our straw option models, and also understand the interplay of what happens to provider reimbursement and if there should be any recommendations from our work group about how to address that. And then finally, a second breakout will occur at the August work group meeting, where we will go back and look at the qualitative assessment criteria that has been developed from our previous work and start talking about how we think these various straw options might or might not address our priorities as a work group. After the August meeting, our actuaries will take the information and further refine the models and be bringing it to us at the September meeting. And we'll be asking work group members to spend more time pondering the qualitative criteria that we'll be getting started with at the August meeting. And then after the September meeting, at the September, October, and November meetings, we'll be developing our recommendations, identifying outstanding issues that still need attention, identify some potential solutions, and talk about what does a transition plan to get to universal healthcare look like. So that's our plan. And with that, I hope that's provided you some important context for our August meeting. I'm going to turn it over to my colleague, Shane Mofford, who's going to talk about cost sharing and provider reimbursement.
Great, thank you very much, Liz. So starting on the next slide, cost sharing and provider reimbursement are two highly impactful components of the overall universal healthcare model. You can actually go to the next slide, please. Thank you. But what I would note about these two really impactful components is that they're also quite complex. So our goal with this section is to ensure that work group members have a consistent foundational understanding of the different concepts related to cost sharing and provider reimbursement, so that they can share their perspectives and inform the model design. To that end, we have also provided documents that explore these issues in greater depth. Next slide, please. So we will look at 4 cost-sharing components found in most insurance plans. These include copays, deductibles, coinsurance, and out-of-pocket maximums. I would note that we are making a distinction between premiums and cost-sharing. Premiums are the costs that you incur to have insurance, and cost-sharing is the cost you incur when you access services while insured. Based on stakeholder feedback to date, we do not anticipate that the model will include premiums and that the model would be funded through taxes. This seems consistent with the philosophy of a universal healthcare model, as it is no longer universal if those that can't afford the premiums or choose not to are subsequently not covered. Next slide, please. Starting first with copays. A copay is an amount due from the patient at the time of service. Copays are typically a flat fee, but can vary based on the type of service. Copays shift a portion of the cost from the insurance plan to the insured member. The same would be true for the universal healthcare model, and this will bring down the overall cost to implement it. Additionally, copays may influence utilization. Workgroup members have differing views on this particular topic. Economic theory would suggest that whether a copay influences utilization will depend on the elasticity of the service. And all that means is that the more the person believes the service is necessary, the less likely the copay will influence utilization. For example, copays for insulin for a diabetic are not likely to influence utilization, whereas high copays for emergency room services that might actually discourage utilization for conditions the patient knows are not life-threatening, such as dental pain. Lastly, it is worth noting that the Medicaid program requires that copays and cost sharing in general must be nominal. They cannot serve as a barrier to accessing care. Further, current Washington state policy does not leverage this mechanism. The work group will need to keep this in mind in order to preserve federal funding for the population that would otherwise be Medicaid eligible. And next slide, please. Moving on to deductibles. A deductible is the amount due from the insured before insurance coverage begins to pay. This is the same concept as with car insurance. You are responsible for payment in full until you hit your deductible, and then the insurance kicks in. Similar to copayments, this cost-sharing mechanism reduces the cost for the insurance plan and increases cost for the insured member. Given the deductible can represent a significant upfront cost for the member, it is even more likely to influence utilization. It again comes down to how necessary the care the member thinks the care is, it again comes down to how necessary the care is from the perspective of the member and how necessary it is relative to other needs in that person's life, such as food and rent. A common feature of an insurance plan is the deductible. However, it doesn't always apply. Medicaid, for example, doesn't use this mechanism. Next slide, please. Next, coinsurance. This is the amount that the patient continues to pay after the deductible has been met. Unlike the flat fee copay, coinsurance is typically a fixed percentage, such as 10 or 20% of the amount due to the provider. As you see in the example, with 10% coinsurance, you pay $95 of the $950 total, and the insurance plan picks up the remaining 90%, or $855. Like coinsurance and deductibles, or like copays and deductibles, this mechanism shifts costs from the insurance plan to the insured member and has a significant potential to influence utilization. Next slide, please. With the multiple cost-sharing mechanisms, having insurance doesn't automatically translate to protection from severe financial distress due to medical bills. To limit an individual's total financial risk, plans frequently incorporate out-of-pocket maximums. An out-of-pocket maximum limits the total amounts an insured member is responsible for contributing to their own care in any given period. Plans vary widely, but there tends to be an inverse relationship between premiums paid and maximum out-of-pocket expenditure. That is to say that the more you pay in premiums upfront, the less you would likely pay out-of-pocket later. For some plans, there are statutory limitations on the maximum out-of-pocket expenditure, such as the example provided in the slide. Further, Medicaid has an out-of-pocket maximum of 5% of household income for populations that are not completely exempt from copays. If work group members decide to incorporate cost sharing, they'll also need to think about financial safeguards such as an out-of-pocket maximum. Next slide, please. In the August meeting, we will discuss these questions related to cost sharing. Do you believe the healthcare model should include cost sharing? If so, which ones and what general parameters should be incorporated? It is also important to keep in mind that policy must be balanced with consumer transparency and administrative complexity. Further, to maintain federal funding for the Medicaid eligible populations and potentially others, compliance with the cost sharing requirements for those programs will need to be maintained. To help the work group think about all of these different moving pieces, we've provided a simple example on the next slide. And first and foremost, I want to say that this is an example and not a recommendation. It's a starting point for the conversation that incorporates a few of the different elements that we've already discussed. This model is broken out by income levels in each row and by the different cost sharing mechanisms in each column. The three income categories are Medicaid eligible, which actually has a few different income levels depending on the aid category. Then the next bracket is individuals up to 300% FPL that are not Medicaid eligible due to income or any other reason. For example, if they have an undocumented status. And then lastly are those with incomes above 301%. The Medicaid eligible population retains current cost sharing parameters, which will also ensure that the federal funds are preserved for this population under the universal model. That means no premiums, no copays, no deductibles, no coinsurance, and subsequently out-of-pocket maximum is not applicable. The Medicaid ineligible population up to 300% FPL is slightly different in this example. They instead would also have copays. The copays would apply to low-value services in pharmacy. An example of a low-value service would be non-emergent use of the emergency room. Because cost sharing has been introduced for this population, an out-of-pocket maximum is also applied. For the example, a range is given, and that range is 0 to 5% of household income. The final bracket further introduces coinsurance. So those that have the greatest ability to pay would be responsible for a greater portion of their own care. So similar to the prior population where there would be copays for low-value services and pharmacy, this population would also have coinsurance, and in this example, the range is from 5 to 15%. They also have an out-of-pocket maximum, and is similar to the last population at 0 to 5%. So again, this is just an example of some of the different concepts that can be applied within a cost-sharing framework for the universal healthcare model. The income brackets could be different, whether or not there are premiums, copays, deductibles, and coinsurance could all vary, and how you structure the out-of-pocket maximum could vary as well. Next slide, please. The next section focuses on provider payment. Specifically, we'll look at purchasing power and the impacts on providers. I want to note for the work group that we are assuming that we will use the current aggregate level of reimbursement in the delivery system, but that there would be distributional impacts. Based on analysis to date, reimbursement rates would be somewhere between Medicare and commercial rates, but they would be nowhere near the level that the Medicaid rates currently are. Each policy decision the work group makes from this point forward would adjust the reimbursement rates from that starting point assumption. It's important to note that a concept such as applying commercial rates broadly likely would make the fiscal impact of the model so high that it would no longer be viable. So again, we would start with the aggregate level in the current system, somewhere between Medicare and commercial rates. Next slide, please. Here we'll start with purchasing power. Under the current system, purchasing power is fragmented. Each plan has less negotiating power and influence than a single payer system would. How we assume the model would use this purchasing power needs to be informed by the work group. Should we assume lower provider reimbursement due to increases in purchasing power? Should we assume better deals on pharmaceutical pricing and related rebates, or potentially even durable medical equipment? We need input from the work group to inform what we should be assuming about how the state would leverage its increased purchasing power. Next slide, please. Another question related to provider payments is one of efficiency. Providers have to deal with different sets of billing rules, different value-based purchasing schemes, contracting with multiple plans, and more. All of this duplication adds to costs for providers, which is ultimately passed on to consumers. A single-payer system reduces administrative burden on providers and likely their overhead. Should the model capture any portion of this efficiency through reduced provider compensation? This is a key question for the work group. Next slide, please. Discussed in previous presentations and in depth in the materials we've provided, we anticipate a significant impact on providers due to the transition to a single set of standardized fees. The direction and magnitude of the impact will depend entirely on the provider's insurance mix for their panel. Providers with a high percentage of commercially insured patients on their panel will see decreases in reimbursement, and those with high percentages of Medicaid will see increases in reimbursement. Please review the documentation we provided. We welcome your feedback regarding any policy around this issue and strategies for mitigating the potential impact if members feel it is important to do so. Next slide, please. So during the August meeting, we'll discuss these questions in depth. Should the model assume lower administrative costs and subsequently lower reimbursement rates due to insurance system simplification? Should the model assume lower provider rates for certain services due to increased purchasing power? We look forward to this discussion later in the month. And with that, I will turn it back to Liz.
Thank you so much, Shane. Now we're going to turn to Nora Leibowitz, who's going to lead us through a discussion about the assessment criteria that our work group has developed, which we haven't seen since February. And so she's going to lead us through where we're at with that and help cue us up for the conversation in August.
Great. Thank you, Liz. So we have been talking about how to assess the various models in many of the meetings, and we've talked some about, particularly about the quantitative efforts, including the ones that Shane was just talking about. We have also been talking about the more qualitative or policy-related criteria, and as Liz mentioned, we first talked about specific criteria, making a list of specific qualitative criteria in February, and those that list came out originally of prior discussions that the group had in its root cause analysis and in thinking about the system improvements, kind of the end state status that work group members wanted to see in the final product. So the work group discussed these qualitative assessment criteria, and then based on those conversations and conversations at the meetings to follow, we looked at the criteria and identified which things really fell into the quantitative elements that are being covered in the modeling, and which were the more qualitative that were not going to get covered through the model, but through discussion instead. So at the August meeting, we're going to be talking about those qualitative criteria, particularly ones Shane was talking about, and then we're also going to have, we're going to have the discussion about the qualitative criteria, and then later talk about more about the results of that quantitative criteria as well in both August and September meetings. So moving on to the next slide. We have an assessment that, this is just kind of a visualization of what's involved in the quantitative and qualitative. So you can see on the left the quantitative, which is sort of the measurable criteria, including things where you can identify either numbers or yes/no criteria. So for example, who's who's involved, how many people will be covered by a model, and will a particular benefit be offered? Yes, no, can be quantified that way. On the qualitative side, these are really about how you develop the policy around the program. And so a couple of examples of that are, one is in terms of equity, the extent to which the model supports the fair and appropriate access to quality care and does so without regard to cultural, ethnic, language, geographic, or other differences in the population. So, and then similarly, as an access issue, one might ask whether the model facilitates people getting the right care at the right time in the right place. So we're going to be reviewing and discussing some of those elements at the topic level, and I'm going to go through first what's under equity, what's under access, what's under those other topics. When we looked at the qualitative assessment criteria, we identified 6 high-level topics that they fit under: access, governance, quality, equity, administration, and feasibility. So I'm going to take the next few slides to go through some of the questions in each of those categories, starting with access. So next slide, please. So thinking about assessing the models in terms of their impact on access for consumers, we're thinking about questions that the work group has raised, such as whether the coverage is seamless. You know, do you have one coverage type for your entire life? Do you have option to choose the providers that you want? And how easy is it for patients and providers to navigate the healthcare system? Additionally, there are questions such as, to what extent does any one of the models provide access to comprehensive, essential, effective, and appropriate health services? Is there access to a full range of services, and is that care culturally attuned? To what extent does is the access to equitable? Is the access equitable, and is it access to quality care that is based on the person's need and not different because they live in a particular geography or have a particular income, age, gender, et cetera. Similarly, in terms of coverage, what types of coverage are included for things like experimental treatments? So in the next slide, we have more access criteria. And some of the other questions around access that have been raised are, is the access to affordable care? Because obviously affordability really impacts people's ability to utilize the care. To what extent does the model promote prevention and primary care services? To what extent is it encouraging the use of that type of care, as well as promoting the workforce capacity to support the types of care that people need, and allowing them to get that care in the right setting. And around behavioral health, including psychiatric care, is that being provided in the least restrictive environment? So on the next slide, we talk about governance as a topic area for assessment. And some of those criteria include the extent to which the system is transparent and accountable in its governance, the extent to which participation in the governance includes community-based systems and organizations, whether the primacy of the patient-provider relationship is maintained, and how the models will ensure administrative accountability to all the stakeholders, including the people of Washington. And then whether and to what extent the governance of the system maintains tribal sovereignty and provides tribal voice, and how does it make sure that the patient has a voice in how the health system works. So moving on to the next topic, there were a number of criteria that we looked at that could be considered quality and equity. And in looking at it, it was important to keep these two together to a great extent, because we wanted to make sure that we were thinking about quality for all the participants, and not just, sort of quality in aggregate that might miss how it was impacting certain populations or individuals. So we're interested in how well the models encourage consistency in healthcare delivery, thinking about delivery in rural areas or across different types of communities, to what extent the model incentivizes the delivery of quality healthcare, and includes efforts to improve healthcare safety, healthcare quality, and minimize things like medical errors. And to what extent the models encourage transparency about healthcare quality, so that people are aware of what is happening in the system. So the idea is to promote better health outcomes. What system is most likely to be able to do that? The next slide identifies administration and feasibility criteria, including how well the model is able to reduce administrative costs compared to what exists now, is able to include mechanisms that reduce duplication of services, and that includes information sharing among providers that's done in a secure way that allows information to be transferred for optimal patient care. To what extent there are effective cost controls for various services, including areas like prescription drugs, which has been identified as a high cost area, while maintaining access and quality. We're also interested in the extent to which a model supports value-based payments, thinking about providing the most value, not just the most services to people. And then thinking about the extent to which one or another model is able to meet the requirements set by the federal government, particularly around programs like Medicaid and Medicare, and to what extent those models are able to achieve political buy-in, get through implementation hurdles, and be effectively administered. So a few more administration and feasibility issues that have come up through the work group include how well the model addresses the impacts of program implementation and administration on a really fairly wide range of stakeholders, including the organizations, the provider side, the payer side, health insurance plans, employers, et cetera. So wanting to make sure we're thinking about how the program works for a range of people and organizations. And then one more slide that we have on administration and feasibility is thinking about how well the model supports administrative simplification and allows for a phasing of changes toward universal health care, as some work group members have talked about, whether we move into a model directly and stay there, or move stepwise. And then to what extent the model really facilitates the sharing of data and portability of data, so that consumers can make sure that they are getting the services they need and not getting duplication of services, but also not missing key information about their health. And then to what extent one or more of these models uses open enrollment periods or allows residents to enroll in coverage whenever they want. So on the next slide, just a quick reminder of the three draft straw options for the modeling. A is universal coverage that's administered by the state, and that's for all state residents with a state-defined benefit package. Universal coverage B is delegated administration, meaning that the state defines the benefit package and sets the rules, but health insurers provide the coverage. So the big difference between these two is A doesn't have health insurers, the state contracts directly with providers, and B utilizes health insurers that then contract with providers. And in both situations the state is setting the delivery system rules and defining the benefit package. Under C, the fill in the gaps coverage, this is really for state residents with limited access to quality comprehensive coverage. The state is defining the benefit package again and setting up the delivery system rules for this new coverage piece, but not across the whole system of health coverage in the state. And it's similar to the Cascade Care program. So just that was a quick reminder of what the models are. So the exercise that we're going to get into on the next slide is in the August meeting, we want to talk about how work group members see each model in terms of its capacity to push forward toward the system that they want. And so for each of these models, we're going to be asking people to think about how well it supports these areas of qualitative impact. So thinking about how well universal coverage or universal A, universal B, or fill in the gaps meets this sort of whole range of access issues or equity issues, and how feasible is it, et cetera. One note is that the work group might decide that, you know, any model has to really stress access or has to really stress equity, and that the final report could include some discussion of those elements that the work group really sees as vital for any reform. So we can talk about that as well in the August meeting. I'm going to give you an example on the next slide. So using access as an example, we're going to want to talk about how well does each of the models support access, and kind of get people's temperature in terms of, does universal A seem like it supports access very much, somewhat, or very little? Similarly for universal B and for fill in the gaps. And then for that area of access, or for access, thinking about whether there's one model that really kind of feels like it's going to be better suited to support access than either of the others. And just as a quick reminder, when we're talking about access, we're thinking about a whole range of elements, you know, everything from seamlessness and choice of provider on down. So it's really about whether folks have a sense that there is one of these models that can promote these criteria more than the others. So we'll be talking about these questions at the meeting, and then we'll be collecting your thoughts on how to communicate the importance of considering some of these criteria, no matter what the proposed recommendations are.
Great. Thank you so much, Nora. That was really helpful. And I hope that work group members are able to really get their brains around this idea of what we'll be doing at our meeting together in August. So just to remind everyone, when we come together in August, we'll be getting an update from Optimus about how the modeling progress is going. And then we'll be taking all the information that we heard from Shane earlier and going into breakout groups and really grappling with those two questions that Shane posed to all of us earlier, so that we can help give Shane and Jared, our other actuary, the information they need to further refine the models for the September meeting. And we'll come back and share that in a large group. We'll then go back into small groups and go through the exercise that Nora just walked us through, where we'll be going through our 6 areas of criteria and talking about how we think these models will achieve or not achieve those some progress in those areas. And then a lot of that information will help us think about how we want to make recommendations on implementation going forward. So that is the plan for the August meeting. And so I just want to say thank you to all of you for taking the time to review today's recording, and also think about the information in advance of August 25th, so we're ready to talk together and use our best thinking. I do want to remind you all that if you have any questions, we have a question and answer period that we are putting out there between now watching this video and August 22nd. So please, if you have questions about the presentations you saw today, please submit them to this email address here, HCA Universal Healthcare Workgroup at hca.wa.gov. And we will be sure to get answers to you in advance of August 25th so that hopefully you have all the information you need when we're together for our breakout session. So thank you all so much and stay safe, and we'll see you on the 25th. Thank you.